Now, we have a 23-year-old gentleman who was well till about 2 weeks ago, and suddenly he said that he started noticing quite a lot of precardial activity with thumping feeling in the chest. On examination, he had a loud continuous murmur in the left upper sternal border. Next. X-ray showed plethoric lungs, some enlargement of the heart. Next. The ECG was showing some LV forces, but nothing remarkable. There was no significant tachycardia. Now, this is the echocardiogram. Echocardiogram shows that the heart volumes were larger. And next, when we looked at the, run it. When we looked at the left parasternal view, there was a continuous color flow from the anterior right. Please continue to show the previous one. Please, the previous one. Yeah, run it. Run the picture. So there was a continuous flow from the anterior right aortic sinus towards the right ventricular outflow tract, and the picture on the left is showing a thin windsock that is formed around the edges, and it is protruding into the right ventricular outflow tract. Next picture. On a transesophageal echocardiogram, next, we found that the orifice was coming from the leftward edge of the right coronary sinus, little away from the right coronary artery, and it was entering bang below the pulmonary valve. The next picture shows the windsock, and next, these are some of the 3D which shows a circular ruptured sinus of Valsalva from the anterior aortic sinus. The anterior aortic sinus is seen at around 6 o'clock to 7 o'clock position on that aortic root. A circular orifice with a windsock that is protruding into the right ventricular outflow tract. Next. So, acute onset ruptured sinus of Valsalva aneurysm that happened 2 weeks ago based on the history with significant symptoms. Dr. Srija is under the echocardiography and she's showing live echo. Can you show the echo big? Echo. Okay, in the meantime, Srija, you can describe the echo.
So this is a long axis view which shows the ruptured sinus of Valsalva from the right sinus entering into the...
Shaq, is Srija audible?
Pardon?
Hello.
Yes, we can hear and we can see the echo pictures.
So it's exiting into the right ventricular outflow tract. There is a mild posteriorly directed AR. Vena contracta is measuring around 2 millimeter. So this is the aortic orifice which measures around 11 millimeter, and the windsock which is seen into the right ventricular outflow tract.
You took some measurements of the windsock in, you can freeze the windsock and then show. We have a catheter from the right atrium, right ventricle going into the pulmonary artery, but this is nicely showing the long windsock. The origin of the orifice was measuring 11 to 12 millimeters. This is 11. Between 11 and 12.
Okay, so let me just ask Martin, who's on the stage. Martin, any views on what you've seen so far of that ruptured sinus?
I would say beautiful imaging, I would say. And it's surprisingly that there's no dilatation of the sinus of Valsalva itself. It's a quite spontaneous rupture. Nice pictures on 3D. I think you can nicely see and appreciate the orifice or the opening of the defect. So I think sizing is quite easy already on 3D.
And any comments about the location of the rupture in relation to the aortic valve cuff? We saw the rupture point very close to one of the aortic cuffs. Just thinking about when we're closing with a device, what the impact of that would be.
Left ventricle.
Can we go back to the image of the echo?
Echo big.
Pictures.
Show the echo. Now this is live echo for you. So you can appreciate that.
The other view, long axial view as well, LVOT, looking at that.
Yes. I will also tell the hemodynamics. The aortic pressure is 116 over 48. The pulmonary artery pressure is 51 over 25. And the right ventricle was 10 more than the PA pressures.
Yeah. So, Martin, show us the long axial view as well on echo.
Okay.
Could you?
Srija, 120 degree. Yeah, rotate.
And where the rupture is, you had a nice view there.
Yeah.
Martin, what do you think of that when it comes to planning device closure?
I think if you're looking at it, I'm looking if it's going to be a rim to hold the device, and of course also the leaflet is getting quite close, so I think you shouldn't have a too bulky device, maybe to avoid getting erosion of the leaflet on the long term.
Could have an impact. Zahid?
I completely agree with what Martin is saying. It is pretty big, and there is no connection to the atrium, right, Shiva?
No, it is in the right ventricular outflow tract below the pulmonary valve. This is from the left side of the right aortic sinus. It's far away from the atria.
It's away from the atrium. So,
Okay.
So what do you think now? Just look at
Angio-
the pictures. I'm just
Angio, big.
trying to get a view.
What do you think as in what device? What do you think
Well,
as
the
in?
device and the impact on the aortic valve.
For sure. I mean, you have to worry.
Okay.
So this is, I think the measurement that I saw in Shodex is
11.
What 11?
Yeah.
It is between
11,
11
so
and
you-
12. 11 and 12.
So it's, I don't know, Shiva, I'm sure you have more cases. I have done only maybe 10 or 12 in my life. These are almost always bigger than you measure.
Yeah,
These are, you know what I'm saying?
yeah,
These ruptures.
yeah.
So I don't know what your strategy is in choosing A, device type,
Yeah.
and B, device size based
Okay.
upon this.
Tim, if you could switch the microphone on, what do you think of the, press the button, switch the microphone on, and tell us what you think of those pictures you saw. Hold on, press the button. Yeah, that's
Yeah.
it.
I think it's very difficult case. It's a very large rupture, and now I really don't have any idea. Put the device and aortic regurgitation and something wrong. It's a really difficult case. I still thinking.
Go to RU.
Any chance of closing the hole by placing a valve, like a Venus P valve in the pulmonary side?
I don't think it's going to close it off.
So I think I would worry
That's a
that it would just,
$30,000.
yeah, I would worry that it would make your access to that hole harder, and you still would have the same leak problem.
Interesting suggestion, though. But the problem will still be, you've got, in order to cover the leak or the rupture, you have to put the valve in low, and then it's going to be difficult to maintain stability. So, Shiva, if we could move you on, what are you? You've shown an aortogram there.
Yeah, this is an aortogram in RAO projection, which is showing the jet, and you can see that the jet is coming out of the aorta at around 3 o'clock, and the right coronary artery is coming out at maybe 5 or 6 o'clock. It's a little away, so the right coronary, which is non-dominant, is not very close to the sinus of Valsalva, and that is commonly the case. The sinus of Valsalva happens at the ventriculo-aortic junction, whereas the coronaries come off from the superior part of the sinus. So very often the coronaries do not get involved in the sinus of Valsalva aneurysms.
So what is your strategy going to be?
Our strategy is, since it is 11 to 12 millimeter aortic orifice, and it's a sort of conical windsock, we are planning to do close it with a ADO1 like device. The size definitely needs to be larger than 11 to 12, but it should not be too large, because there is already some degree of right coronary cusp prolapse, and there is a mild posteriorly directed AR. So I should not worsen the AR with the device. So my plan will be to try a 14-12 duct occluder device. Now about
which has an aortic disc of how much?
The device that I'm going to choose will be having 16 millimeter aortic disc, 14-12, and it will have a length of.
Shiva, which duct occluder are you using? Amplats or some other?
No, okay. If I am choosing the Amplatzer duct occluder, the length of the Amplatzer duct occluder is 7 millimeter, and so it does not protrude significantly. There will be some more residual windsock that will be beyond the pulmonary end of the. So I want it to be a little longer than that. So I'm going to be using a memo part Lepu Medical duct occluder, which is 14-12, which will have almost a 9 centimeter height. So it is little bit more longer.
What about the flat side on the aortic side?
That is
How
6.
big would that be?
That is for a 14-12, it will be 18.
Yeah. Okay.
Okay.
18.
All right. So if we could just keep you moving, then Shiva.
Yeah. So what we are going to do is.
It is difficult to do, but whilst you're talking, if you can carry on working as well, rather than
so
stop.
what we have done now is I am having a right coronary catheter which is facing the aortic sinus, and I am trying to cross the leak. So it has crossed. It's going into the pulmonary artery. And now I'm advancing my catheter, and I already have got a snare catheter ready there. So this snare catheter is going to open out. So now let me see whether, can you come to AP view? I want to know whether both are in the same PA. Yep, so I'm advancing. I think it's not passing through and through. So let me come. Okay, it has got it. So
yeah, you got it. Oh no, you missed it.
No, I have missed it. Sorry. Okay, I was just.
But Shiva, this putting the catheter, snare catheter before a crossing, it's a great idea. I do that for VSVs all the time because it actually shortens your procedure time quite a bit. So that's very good now that you should be able to.
If you can snare the wire.
If you can snare the wire.
Yeah. So let me again try. Okay, catch.
And again. Keep working, but my question was going to be, would you contemplate, don't change your strategy now, but would you contemplate a retrograde arterial approach and deliver a different sort of device?
Yes, yeah, we
can. The aorta?
In fact, yesterday Dr. Joe was mentioning to me that he would like to think about using a muscular VSD device, retrograde. And he was telling me that it is not very difficult to, in an adult patient, to have to keep it gripped nicely.
Okay,
so in a adult patient, it is not very difficult to put in an 8 French arterial sheath. He was mentioning. So I'm a little going slow. I don't want the windsock to rupture more. Okay, so I'm keeping a. I don't want a tension on my.
Yeah, and then the other question was going to be, apart from doing the circuit, the delivery is because it'll be at an angle from the RV outflow tract into the aorta.
Exactly.
And when you deploy a disc and pull back, it will be not necessarily in alignment with the ruptured sinus. So that's going to be a technical challenge as well, isn't it?
Yeah. So what I'm planning to do is take a Mullin sheath, go with the tip of the Mullin sheath well into the descending aorta so that I have the entire curve of the Mullin sheath on the, I want 2 forceps, artery forceps, clamps. Yeah. So I will try to push the Mullin sheath's curve into the arch of the aorta. Let me see how it goes. Put another clamp at this tip. So what I do is, in order to keep the circuit, the wires.
Shiva, given a choice, would you rather use some other sheath, or you like Mullin sheath?
Most of the cases I use Mullin sheath for everything. Even for ASDs, I use Mullin sheath. Because we find that it is thinner in its because it is non-braided. It doesn't have a larger profile, and the Cook has got the best of the hemostatic valve, so it never leaks.
Yeah.
So for some reason I prefer Mullin.
It's a very nice sheath if you want to kink it on various tight bends.
Yes, it does seem to. That's why I know this looks like the angulation, how the way you crossed it's very straightforward.
Yeah.
But if it was slightly curvaceous, I know that Mullin sheath do tend to kink rather easily.
Yeah.
That's what I was.
Correct. Actually, it is quite prone for kinking. If the same thing, if I had kept the sheath tip just in the ascending aorta, there will be multiple kinks. But that's the reason why I have taken the entire curve of the Mullin sheath to go into the arch of the aorta. Now I'm ready with the device. Can you open the device, please?
So this is 8 French, did you say?
Yeah, this is an 8 French. Does it need an 8 French, or I have oversized 8? What is the recommended? Oh, sorry, this is 9 French. Actually, it is supposed to go through a 8 French. I think we have oversized by 1. Yeah.
What? 9 French?
9. Yeah, this is 9 French, but
okay.
this is I can use an 8 itself. I have.
Yeah, I wouldn't worry about 1 French. It's an adult patient.
Yeah. So now I'll
But
show
also, can we have a quick look at show the device and then have a quick look at the color Doppler with the sheath through? But
Yeah.
show the device first. Yeah.
Srija, can you show the color Doppler? So this is the device. The device looks like an Amplatzer duct occluder. The difference is that the height of the device is a little longer than an Amplatzer duct occluder. So,
The other one with a longer shank, but it doesn't have a longer shank in the larger sizes, is the Occlutech.
In fact, we thought about an Occlutech, the 12, actually, I would have chosen a 1512, but I think the 1512 had a 11.5 centimeter length, and we had a doubt on whether that might how much? 14. Sorry, 14. 14 millimeter. 14 millimeter is the length. Oh, okay. A 1512 is 14 millimeter in its length. So we were thinking whether it will protrude too much into the right ventricular outflow tract below the pulmonary valve. So that was one of the concerns.
So quick show of the color Doppler if you could.
Srija, color.
But as I say, carry on with your device insertion.
Yeah, that is the color. AR has not worsened now. Can you show the echo live?
We don't. Yeah, that's it. All right. No change in the color, so it's quite. And you wouldn't consider.
Yeah, there is a kink there. I'm trying to negotiate.
Yeah. It really kinks very nicely, this sheet.
Yeah.
Yeah. Yeah, it definitely. I don't use it. I know you said you like it. I tend not to like this sheet. I like Chuck Mullins way more than I like this sheet.
Yeah, it keeps kinking at all levels now.
Yeah, this is what concertinas now. Where as you push the device, it will move the kink further distally.
Yeah.
Shaq.
Yeah.
Collier wants to know if what about a safety wire?
Sorry, where are you?
Yeah, just up here on the left. You're right.
Get the RCA.
Who wants to know?
Collier wants to know, but he's afraid to press the button.
No.
Why not use a safety wire?
Yeah.
Well, he could do because he's got one French bigger sheath than is needed anyway.
Safety wire to keep the
keep the sheath in place.
The crossing is easy. Yeah.
Yeah. So what I'm doing now is I'm going to grab the tip of my sheath now. Let me see how it comes.
And then pull it down. Yeah.
Let me see. It's not.
I don't.
It's possibly. Can you go on to lateral view? It is, I think, hitting the posterior wall.
The sheath is against the wall, isn't it?
Yes.
It's not. It doesn't sit nicely. Yeah, you see
What
it's at the back.
I know you're fairly deep, so can you pull
sure.
the sheet back a little bit and see it might advance?
No, it'll bounce back.
Listen. Can you pull the sheet back a touch?
Hang on, let him.
I'm just trying to get it garlanded. Let me see.
All right.
I'm not planning to pull it. I just want to grip it so that I'll.
Yeah, I know that will give some oomph to the sheet, and then you will be able to advance the device.
Can you hold hold both together? So, sister, hold nicely.
There you go.
Yeah, well done.
So now release it, sister. My nurse here was gripping it nicely so that, okay, now we have got the ball out. Okay, Srija, now echo big, fluoro and echo, take away the hemodynamics. Yep.
Are you going to stay in lateral or are you going to go back?
No, REO.
REO.
So mostly I'm going to be based on the echocardiography.
Right.
Srija, I'm fine. So keep concentrating. So I'm keeping a little bit more. Just rotate and see whether the device is already closer.
Here. Then.
Okay.
It's coming.
Okay. Now I want the hole to be opened. Can you put an X-plane there so that I can see in both the views?
Shiva, the mushroom portion is completely out or no?
Mushroom portion is?
Is completely out?
Completely out. Completely out, and a little bit more I have released.
Okay.
Yeah.
Okay.
Stop it flicking back.
Okay, the cable is giving actually what is happening is the device has become a cone within the windsock. So after I release it, I hope it will get a memory and it will form itself better. But there is a small possibility of a reverse embolization, which I feel may not happen late in this evening. I think.
It looks kind of. It looks the mushroom portion looks well rounded to me.
Now
You know,
look at the aortic valve now. Are you happy about this aortic valve? Now you see.
Can we see the color Doppler? There's a bit of regurgitation.
Yeah, but it looks the same, no?
Slightly more.
Is it more?
Slightly increased.
See, previously also the color was hitting the anterior mitral leaflet and not going beyond the middle. Now can you get the full length of the air jet? I think it was more or less the same. Can you quickly? Oh, okay.
No, this is more than what you showed originally.
Okay.
And it's getting more.
Okay.
This is
now
definitely mild to moderate AI right now.
Moderate means it should cross the tips of the AML. Now can you show me a little bit more of the LVOT? Now push the probe inside, Srija. Push it inside. Show more of the LV. A little bit more inside. Little bit more inside. Yeah. Now put the color, so that you see a lot of LVOT. Okay.
Broaden it.
Keep on rotating till you get the maximum AR.
It's more than baseline.
More than in the sense what? In like what objective criteria? Is it the vena contracta or the length of the jet?
Length of the jet also, the breadth of the jet.
Can you measure it? Can you zoom on that vena contracta and then measure? Zoom maximum. Yeah. Record the okay.
Yeah.
No.
Shiva.
Yes. Yes.
Peltonen was just whispering in my ear that he was asking whether you think or Shita thinks this is a VSD with right coronary cusp prolapse.
Okay. Now can you see whether there is any? We didn't see any.
I don't think it is.
We didn't see a flow from the LV to RV.
Al-Khanan is hungry. Have some food.
We did not see it. In fact, many of the subpulmonic VSDs which spontaneously close with a prolapse of the right coronary cusp may have this as a late sequel. We did not find a LV to RV jet. And even now it is not there.
But this is also, it's...
no, this is old pictures.
It's pointing towards the right ventricular outflow tract. So
now you show me the same...
Unless it's doubly committed.
No, actually there is no VSD now. Now see, one of the option I am thinking is, see the device is causing a tension. It is actually pulling the disc towards the right ventricular inflow because I have a cable that is holding it. If I release, whether that will create a turn in the aortic, sort of change in the aortic valve geometry. You see that basically the original cuspal prolapse, the windsock was directed towards the outflow tract. And now I am dragging it towards the inflow tract. The moment I release it, it is going to go back to its neutral position. So whether that will result in a better aortic regurgitation.
Well, it's unpredictable, isn't it?
I think it's oversized.
Yeah, sorry.
I think it's oversized.
Okay.
It's oversized, you think?
Yeah, it's impinging on the valve, so it's not good to leave it.
If you have a smaller device, there's already some leak here, but these are almost always are bigger than the low.
Yeah, the problem here is the tension because you can't push the cable because it's actually going to move it towards the lateral wall.
Yeah, because the sheath is not going to come coaxial to me at all.
No.
Yeah, so now when I am dragging, will I cause more harm to the aortic valve? Now you see how it is?
Some residual flows.
Yeah, so now there's more residual flow and AR.
Yeah, so I'm trying to take it out. The issue is...
Shiva, are you going to take the device out?
Yeah, that's what I'm planning to. It is coming in. 1 second.
No, it's out.
It's out.
Okay, so now what I will do is, I will take another circuit. It has ruptured much bigger than what it is. Now
it looks bigger now, doesn't it? Yeah.
I have to use the same device, I think. If
same
at all.
Or,
Yeah, see, finally it is.
Remeasure, yeah.
I think I should
remeasure.
have released it at the time, Shaq, because what I was thinking was the windsock was directed only originally in one direction and I was pulling in the other direction. So I thought that was twisting the aortic valve leaflet. So my thought process was just to release it.
Yeah.
However,
I think that was a good process. I think so.
anyhow,
I agree with you. I think if you release it, the AI may get better.
but now I cannot. I have pulled it out. Now
No.
I will go back again, sister. I want. I'll just take another circuit.
Shiva, can you have your sonographer measure the hole now?
Yeah,
If
yeah.
It's bigger.
She's
it's almost
measuring the
same.
same 11.6
almost
now,
the same.
fortunately. So
12.
So do you think, are you planning to use the same device or
definitely,
change the
definitely
size?
come to APView. Definitely not a smaller device, Shaq. Now that the hole is looking
Absolutely,
bigger,
yeah.
but I will try to now this time use a braided sheath as Zaidamin was suggesting. So I have the snare ready there. Come get me the coronary catheter, J wire.
Shaq?
Yeah.
I think the aortic valve the problem due to the left side
Srija,
is not the ideal
Srija,
one.
can
is
you
so
find
steep.
out what is the AR
And
now?
can we move?
Yeah.
Can you
Hold on,
ask
Sid.
him? Can you ask him to choose the
Say it again
MFO?
because she was. Say it again.
It's the same.
You see the left side is of the ideal one. This is too steep. And I think we can change to the MF4 or some other device. The left side is softer and maybe better than the ideal one.
The largest MFO is 1412. It will fly into the right ventricular outflow tract. It doesn't have any strength at all. So if it is something like 18, 16 MFO, then I will think about it. Dr. Joe was suggesting that he may be happy about using a retrograde VSD device. That is also another option. Maybe we can go for a 12 VSD device. The problem about using a retrograde 12 muscular VSD device is that it will be tough for me to assess the aortic regurgitation with a cable that is actually pushing it down. Let me see whether I can get. Yes.
Shiva,
Hold on.
How about retrogradely? Yes, Jack. How about retrogradely implanting an AVP2 device? Because I've used them in perimembranous VSDs with big aneurysms, and they're very soft. And I think the disc shape, the ADO type device I think the disc itself was what was jutting into the leaflet. And if you had something with less of a kind of disc waist change in size, you might be able to pull that more into the aneurysm.
A good, interesting suggestion. Right now, you were going to say something. Zaid was going to say something very important and profound, but he forgot.
No, I still believe that if you put a 12 muscular VSD device, the disc is 20, right?
Yeah.
12 plus 8, correct?
That's 20, yes.
Braided
right,
sheath.
yes.
Braided sheath.
Yeah, so I am still significantly in favor of PD, the 1 year use.
Okay. Well, AVP2 is an interesting suggestion because especially if it's retrograde, because you can adjust the aortic disc, aortic end of the disc higher up because you've got the waist in the hole. So there's less interference or less likelihood of interference with the aortic valve cusp. Is that what you're saying, Radwan?
How big an AVP2 you will have to use?
Well, I don't know. It depends on remeasurement now because if
Shaq, if it is a 12 millimeter, then what AVP2? Shaq, I am not very comfortable in using AVP2 in such a high flow situation. It may sit now. In another 15 minutes, it will be in the pulmonary artery.
You'd have to oversize it by 50%. So you'd be looking at an 18 AVP2 at a minimum.
I agree with you. High flow situation, patient will have hemolysis most likely, and then you're in bigger trouble for several weeks.
Shaq, will you think about an AVP, or will you think about a software device? First of all.
No, I would be more likely. I'd be thinking of a double disc device like a muscular VSD, but from the arterial approach.
Okay.
Because what I would do is pull the right ventricular end right into the windsock and have the aortic end actually sticking away from the aortic valve leaflet.
The concern that was expressed by Dr. Zahid is the same that I also have. Like you are having a much larger disc because there is a 4 millimeter protrusion of the flange. Yeah. So does it concern you?
That should concern you, right? If it's a 20 millimeter, he has to put at least a 12 muscular VSD device.
Yeah.
This is going to be 20, and that's going to distort the aortic valve.
No, but if you pull the disc up and have the waist, the right
Then the
ventricle,
more disc is at the aorta,
it'll be higher up, away from the leaflet. It'll be away from the base of the leaflet.
Most of the ruptured sinus of valsalva that we have closed are all
Warren,
using ADO.
Shiva,
Yes.
Warrakan.
Yeah,
Shiva,
Warrakan. Yes.
just to say something. I think the equation now is you cannot use the disc on the aortic side larger than 20 millimeter.
Yeah.
And you know exactly if you deploy from the aorta back, it will be the tension on the cable, and then you cannot coaxial with the axis of the lesion. So in my feeling, I think we probably will go retrogradely. That's one thing. Second thing, I'm thinking maybe if we can use the Occlutech VSD device, which probably the disc on the other side is smaller. So that's probably one of the possibility.
Okay.
So please consider that.
Okay.
So
And
what sort of Occlutech device? Now you need 12 muscular, right?
No. The PMVSD device.
PMVSD device
The
12.
PM
I don't have it,
Occlutech
Warrakan.
PMVSD.
I don't have. I exhausted 8 and 10, whatever I had today in the first two cases. The only Occlutech
All right,
perimembranous that I have is 6, I think, small one.
Yeah,
now,
You can't use it.
Shiva, one more question. Is that Khalid? Okay.
Srijak-
Yeah.
Srijak?
In fact, I wanted to say about the Occlutech device. PTA Occlutech device is softer, although it protrude a little to the RVOT, but he's an adult patient.
I have pulled through.
That came through easily. Yeah.
I think the hole is bigger now.
No,
Shiva.
no, actually, Zahid, what I did was, in fact, I was giving a little higher traction. Possibly, I'll just give another try once again. I was trying to listen to the idea of Occlutech, and I was thinking about it, and my hand was pushing it too fast. I'll just
Shiva,
do it once. Yeah.
Shiva.
Yeah.
Yeah. You carry on, but don't think and do at the same time, because your brain will get confused. So just work out a plan and take your time and don't rush it.
Sure.
Bharat, whilst Shiva's thinking, any suggestions from you?
I really came late, although I saw a part of the case from outside.
Oh, right.
But
Okay.
I came a little late. But if it is opening into the right ventricular outflow tract, sometimes the stretch on the cable is so much if you come from the femoral axis that retaining the device in the anterior third of the right coronary sinus may be difficult. And retrograde approach may need to be considered.
Yeah.
Arevo?
Is that Sachin or?
Yeah.
Okay.
Considering so many attempts have been made to cross, should we not leave a wire across it?
Should we what?
Leave a buddy wire across.
Buddy
because
wire, yes.
It's been so many times.
Earlier on, there was another question at the back. I thought.
It's just a comment. I mean, will a PFM coil be suitable here? A PFM coil will conform to the sinus. I mean, a bit softer.
PFM coil, that's an interesting one. It's quite floppy.
No, and second thing is, Shaq, the flow through these fistulae are massive.
Yeah.
I mean, the coils, I don't think will sit there. They'll just fly off.
Yeah.
Also, residual shunting and
Hemolysis, it's going to be an issue, certainly.
You need something that
far
has
stiffer device.
All right. Let Shiva think and slowly do.
Catch.
Stefan.
No.
I think
What's
they're
the situation with
we're
Frankfurt?
ready there. We can skip. You want to skip now? Because we could do it now.
So, Shiva.
Yes.
We're going to go to Frankfurt. Well, we are in Frankfurt. We're going to go to CVC.
Okay.
And then we'll come back to you when you're ready with your circuit and everything. Yeah.
Sure. Okay.
So, Shiva.
Yes. So what Shaq, the changes that we have made, it's the same device, it's the same sheath. Now I was hearing about using a support wire there from Sachin. The issue about having a support wire is I can only have a 1/8 support wire and not something bigger than that. A 1/8 support wire that I'm having, either a V18 control wire of Boston Scientific or a Roadrunner, all will be sharp cutting edges. So what I'm doing is now I have put in a pigtail to serve as a landmark where the sinus is. So I'm having multiple landmarks now. One landmark is show me a little bit of contrast. One landmark is catheter, just contrast. Now I'm going to come a little closer. You hold it so that it doesn't pull through. No, you have to allow me to go. So Srija, are you seeing the device?
Yes, sir.
Okay, now I'll stop here. I'll see where is the level of the sinus.
This is where it deforms, but carry on doing things. But the advantage of MFO is you could actually attach it from both sides and keep control of the disc delivery.
But what size, Shaq? It's 11 to 12 millimeter. How can we put in?
Yeah, that's the difficult one, isn't it?
If they have about 2 more sizes extra, then I'll be happy.
Yeah.
Yeah, it just drops.
Oh, there you are. You see, it's come through again.
Yeah.
So you're going to have to think about an alternative strategy now.
Yeah.
Such as a retrograde arterial approach.
Definitely, or bigger.
Or bigger device.
Yeah.
Okay. So we'll let you think carefully and slowly.
Yeah.
Very important this.
Yeah.
And then we'll come back to you.
Show me that Occlutech muscular VSD device.
Where, Shiva?
Yep. Yeah, Dr. Shaq.
We will come back to you.
Yeah.
We'll just give you a bit of breathing space to think.
Sure. Shaq, we are, the concern is now the same device is pulling through. What we have chosen is 1412 that's pulling through. The next size will be 1614, and originally we had a concern on 1412's retention skirt itself sitting on the aortic valve quite a lot. So now I am I don't like 1614 will be even more like injury to the give that 1512 Occlutech PDA device. So the 1512 will be even more. So I'm thinking about so instead of 1614 I'm taking a 1512 Occlutech PDA.
Okay. And that's got a longer shank or
it is not a longer shank, it's a standard shank. Take top open.
Okay. All right.
So get the correct cable for this Occlutech. One of the things that confuses is all the colors and all like so
7 millimeter.
So I'll just show the Occlutech device now once. Show me here.
Okay.
Get me the correct type of cable for it.
12, 15.
It's quite long. You see here. And
yeah.
Okay. Okay.
Yeah.
It's quite long, little softer, and it is 1512. Can you give me the correct cable, sister? And
Shiva, what's the flat size? The flat edge. How big is that?
Yeah. Can you read out the 1512's aortic retention skirt? 1512 is 20. Okay, it is 20. 20 is the aortic retention skirt. What was the aortic retention skirt in our previous device? That 1412 that we chose?
18. You said 18.
18, yeah. So that is 18 and this is going to be 20, a little larger. But the only thing is that maybe the softness of the device, let me see how it works. I'm not sure. Now the retrograde option of a muscular VSD device, I am not having currently. You will need something like a 14 millimeter muscular VSD that will have a very large 22 millimeter aortic retention skirt, which will make it even bigger.
Yeah.
But you could use a 12 though. If it's a double disc muscular VSD,
actually,
you could get away with
Orakan was suggesting that this Occlutech can be loaded retrograde and I can have a smaller aortic skirt and a larger PA end. Is that not Orakan? Yeah, yeah, but I'm not sure about the stability, Orakan.
Depends on what do you have. I think that's probably you are now with the PDA device, or maybe you can try, but we'll see.
See, I don't have a muscular VSD device, but the same PDA device, if I go retrograde and try to put it, like yesterday we saw Kevin Walsh loading a PDA device, a VSD device, the cone in the opposite direction. Like he was putting the cone in the LV and the flat disc on the RV.
Shiva, Bharat is going to say something.
Yes.
Go on, Bharat.
Shiva, sometimes what I have seen, when there is such a steep angle between the inflow and the outflow, the stability of this retention skirt is not good. So it may not be a bad idea to open up the device entirely into the aortic root and gently bring it back so that the retention disc rests on the aortic cusp. Sometimes it seems to work that way.
Okay, let me see. Okay, take this wire out, sister. Let me see where it goes. And okay, that's the aortic sinus. I'll put it on pressure. The last case of the day is quite challenging, Shaq.
Yeah, well, you deserve it.
The cath lab efficiency session said you put the most complicated case last.
You'll sleep well tonight, Shiva.
This is a tradition in CSI Frankfurt. The last case goes on and on. I'm afraid, so
take my glasses off. It's fogging. Just take it out. Yeah, thank you. So
it'll probably work when you can't see anything.
Yeah, but I'm not hypoglycemic. Adrenaline is full.
I do.
0.5 mics per kg per minute. Okay, now I am Bharat told to release more.
Can we see also echo?
Can we see the TOE?
Yeah, TOE is there. Okay, show the TOE next. Hemodynamics out. Hemodynamics out. Echo. Show the echo big. I don't know the transmission person also whether they're.
Two pictures we want, fluoro and echo.
Good shot.
Okay, so I have released.
That's it.
Yeah, that
Okay,
good, no?
so now let us see color, aortic valve, the test. But this residual flow, I'm not concerned. Occlutech always has a lot of residual flows and then
device
settles.
Has that tendency,
Yeah,
yes.
this device doesn't stop immediately. You have to just see the anatomy and wait for it patiently for 24 hours. And this has happened many times in PDAs, larger PDAs. There will be a lot of flow through the fabric. Unlike LifeTech or something which uses some PTFE-like fabric, here I think it's a thin polyester. Srija, are you happy about the device position?
Yeah,
okay, now get a AR color. Okay, now what I'm going to do is, let us give a pressure angiogram.
Okay.
It is going to show a lot of residual color. However, I'm just looking at the alignment of the device. That's all.
Did you capture it? No. Okay. Run.
Okay, I'm just giving a little bit more slack on the device so that it doesn't pull through.
Yeah, the problem is the tension is away from where the device is. It goes towards the
that's why I'm trying to push it towards the pulmonary artery. Okay, are we ready for an injection? 25 ml at 15
I will do
rate.
injection, and if you like it, you should release it sooner.
I'm going to release it now.
No.
Iodogram. 25 at how much? 15.
Is your pigtail too low, Shiva?
Oh, sorry. One second.
That's all.
Sorry. I'll you're not injected, right?
Okay. That's better.
Okay. Are you ready? Keep it.
The disc is little.
Disc is little tilted.
No, it's getting tilted.
No, that is because I am actually pushing it towards.
No, but
now you see the disc whether it is better. Okay.
it was about
Did you see that?
Yeah.
Yeah.
I would seriously, this device would stay if there was not that much pull. So I think we are wasting a lot of time.
I'm not sure.
Huh?
I'm not sure. Yeah.
Shiva, remember I said to you, they are always bigger. And we see that.
And you know, Shaq, unfortunate for him, despite there being a rupture of this diameter, the sinus of Valsalva is not at all dilated, and that is why that disc is compromising on aortic valve function. It's really unfortunate anatomy. Such a large defect, and yet the aortic sinus is almost of normal size. Quite unfortunate.
It was coming.
So your next plan will be muscular VSD, Shiva, then, or bigger?
What do you suggest?
PDA device.
I'm now convinced that the tension on the cable is what is causing the problem.
Yes.
So
I agree with you.
Can you remeasure now? Remeasure. We'll think about a muscular VSD retrograde. Actually, Dr. Joe told me to take a muscular VSD right at the beginning, yesterday.
Right. Yeah. Shiva. So we'll come back to you. We're just going to rejoin Frankfurt again.
Yeah.
So we'll come back to you. Yeah.
Sure.
Just give you time to think.
Shaq, I went retrograde now. This is a 14 millimeter muscular VSD device, which has got 20 millimeter disc on either side. It has got a 7 millimeter waist. Now,
and shows the PoE
echo, please.
You're producing too many echoes.
Okay, sorry. Color. AR.
Have you done aortogram yet?
No. Just now I deployed. Can you show the previous deployment?
Okay.
It is.
So the color through the discs, I think that looks okay. It's really the AR, isn't it, that you have to make a decision on.
I would aortogram and let's see. Maybe you don't.
Yeah, I'll get an aortogram now. This die?
If this is too much AR, then he's a bad surgical. Unless
I will be worried about the AR.
That is.
I would be worried about the AR. If you look at like that, you're definitely doing something.
This is actually flow into the right ventricular outflow tract only. Let me change the position. Can you get lateral view?
Bharat, from what you've seen, what do you think?
No, I'm a little concerned about the aortic valve.
Yeah. So what would you do now?
Maybe I would accept that given this anatomy and given the size of the rupture, it may not be a great idea to do it percutaneous.
Shiva, you have an arterial line to do aortogram, or
no?
I have to inject through the sheath.
Yeah.
And Shiva, baseline there was no AR at all.
No, there was a mild AR. Show the previous AR, Srija.
See what happens, Shaq, sometimes what happens is when you take away this low pressure circuit out of the aortic outflow, the AR tends to get a little more exaggerated for the same anatomy.
See, I will show you one thing. The aortic systemic aortic pressure is going up now because the diastolic runoff has stopped. You now see show the aortic pressure. That can lead to show the aortic pressure now.
That can lead to transient increase in aortic regurgitation.
Show the aortic pressure. Show the hemodynamics. Not hemodynamics bigger. You see now it is 160 by 88.
22 millimeter disc. The aortic. Hold on.
Yeah. So Shiva.
Yes.
The diastolic pressure has definitely gone up, but just show us the pre-anything.
Yeah. Okay. LV angio. LV. Show the echo now. Big. This is without anything. Show the echo big. So this was the amount of AR before.
Oh, so it was there. Yeah, it's slightly more than I remembered. But
Srija, there was
there a catheter across?
No.
At this point there is no catheter across the RSOV, but there was a catheter across the pulmonary outflow tract.
Okay, so the AR.
Show another picture. There was another
either the same or slightly more, not much.
Now you show live Srija.
Currently. Do you agree, Bharat?
I completely agree. I don't think that he has really done any significant harm to that aortic valve.
Yeah.
I can give a hand injection. I think. See, I'll put it inside.
Yeah.
Give a little bit more.
Well, actually, I'm convincing myself that the AR is about the same as it was, only marginally more. So that's not too bad.
I'm going
and
to
the flow through the device that's acceptable.
Well, if it doesn't work, you can go to the wall.
Yeah.
After
Warkan, what do you think?
Well, to be honest with you, I think I have to accept the AR, and I will release the device. Why? Two reasons. First,
give about
if AR progress, I definitely will send for surgery.
Sorry, say again. Yeah, go on.
So it means that I will accept that AR, but if you ask a surgeon, they will say I can fix both.
15 at 15.
Sinus valve server and fix the AR. So what does it mean? It means that once released, if AR progress, I will send for surgery definitely.
Yeah, that's fine. But at the moment,
at the moment, I will release.
Yeah.
Because I think that's the best that we can offer for this patient.
Okay. Rafael, where are you?
One second, Waleed. A couple of things. Look, the disc in the aorta hasn't even formed yet.
Show me the echo now, Srija.
Look at it. Look at it. It hasn't formed yet. It's a 22 millimeter disc.
Yeah, go on.
Okay. If it forms and the air hasn't changed, then it's a great idea.
Yeah. Okay.
In my
All right.
Actually,
So
I am not able to separate out.
Make the disc form.
I am not
give
able
it time
to.
for disc to form.
No, I'm not able to separate out the flow into the right ventricle from the flow into the left ventricle here, because in both these views, lateral view as well. See, this lateral view has got it shows. I don't know whether there is an overlap of RV and LV also. Show the previous picture. I am not able to separate the two now.
Shiva, a couple of things.
Show the previous.
Shiva.
Yeah.
Hey, my friend, can you make sure the disc towards the aorta forms and then can you check the RVOT too now?
RVOT show me, Srija.
You know,
RVOT looks open. You see, that is the pulmonary outflow tract. Color, no?
Khalid first and then Rafael. I want to pick on.
RVOT is fine. Srija, can you get the AR again?
I would agree with Dr. Warakan to release the device.
Khalid, start again.
I would agree with Dr. Warakan to release the device.
Yeah.
It would be
show me in RAO position.
And this is what he can do now.
Yeah. Okay. Yeah. Rafael, what do you think?
Yeah, I think release.
Release as well. Okay. All right. So what do you think, Shiva?
I'm thinking about releasing. I am happy about the position of the device. Srija is having a concern about the stability, but I feel that it should be stable. Let me see. I'm now releasing.
The worst scenario will be he needs to go to the OR, but I would agree with releasing.
Okay.
Now Srija, look at the AR. Doesn't look very bad compared to what it was before.
Yeah.
Actually, it looks similar to the one pre-procedure.
Yeah. Rotate in all the planes, Srija.
Shiva, what do you think about this disc on the aortic side? Why is it so flat? You think you're in the aneurysmal portion, and maybe that's a blessing?
Well, the TOE shows that he's on the aortic side of that.
But you see, the disc on the pulmonic side is much wider.
Yeah.
Right.
Pulmonic.
So maybe it's a
pulmonic side is flat.
Yeah. But the aortic side.
But remember, it's right into the aortic root, so the part of that disc is going to be compressed, as it were, by the root. It cannot.
Color the aortic valve now. It looks okay, Shaq here. Yeah, there is AR, but maybe
which was there before. So do an aortogram now.
Okay. With the sheath itself, or shall I put a pigtail? Pigtail, 6 pigtail?
I would do a pigtail because a sheath will direct the flow or pressure towards the device.
I understand. Yeah. Can you get it?
And then it's.
Did I make a simple case too complex on the last session? I'm sorry about it.
No, this is good case. This is excellent case. Tells us how little we know about these.
But also, it's very educational, and that we've got quite a number of audience participants here as well. There.
Oh, still people are there? I thought the hall will be empty.
Not at all.
But
okay.
Maybe half.
All right. Just to show you that they're here, can we give him a big round of applause?
Did you hear that?
Yeah, I'm able to hear. Okay.
So that was a recorded applause for you.
Okay, thank you. Thank you. That's what you hear in the Comedy Central and channels like that?
Yes, exactly.
Okay.
Yeah.
You are ready? Yeah, no. Give a good volume. 25 ml at 15 rate. 25 ml, 15 rate, 1000 psi. Good injection. Ready?
Yeah. So there's a flow through the discs, and there's AR, which was there before. So I think I'd be happy with that.
Yeah.
If I do an LMO, will I separate? But I don't know whether this is. I mean,
Shiva, how is it going to make any difference now?
Yeah.
So I don't think you should give any more contrast.
Okay.
Yeah. The only thing is that this patient might hemolyze. So keep a good watch on hemolysis.
Yeah.
Okay.
So, Shiva.
Yes.
What's the, just read off the pressures, don't necessarily go to the hemodynamics to show us, but what's the aortic pressure now?
I'm just going to connect it online. Show the hemodynamics. I will.
No.
Okay, that is the aortic pressure. It's quite high.
That looks nice.
It's very high, 200 by 110.
I meant the diastolic, sorry.
Yeah, diastolic's up as well. So.
Yeah, little bit of some agent to control the blood pressure. Ask for some nitroglycerin or some infusion to reduce the pressure. Yeah, start it.
Yeah, so reduce the pressure so the device doesn't embolize either.
And the AR also doesn't increase, hemolysis doesn't increase.
And also hemolysis.
Hemolysis as well. So Shiva.
Yep.
Shiva, what time is it?
It is 8 o'clock.
No, it can't be.
8 p.m. Oh, maybe 10 minutes to 8. Yeah. That's what I'm seeing on the clock. I don't know. What is the time now? Yeah, 10 minutes to 8.
Okay. All right. Well, your team have been really excellent, dedicated, obviously, staying on till 8 p.m. Missed lunch and dinner probably by now. So can we show our appreciation?
I will introduce my team also now. Come here. He's Prabhu, the radiographer, Ravi, who is the head of the radiography team. Yeah, he's here. And many nurses headed by one, Theresiama. Bhushan is my colleague, Srija, Raghu, plenty of people. Actually, this is a very overloaded, big department.
Siva.
Yes, Neil.
It's Neil. I want to see Ravi.
Ravi.
Where's Ravi?
Yeah, that.
Ravi, huh? Nice to see you.
Ravi says hi to Neil. Actually, this lab has been visited more often and more number of interventions has been done by Neil Wilson than by me. And so everyone fondly remembers all those nice old days when Neil used to do highly complex interventions in this place. And we wish he comes again one day.
Not as nice and as well as you've done, Siva. That's been a fantastic day's work. Really, congratulations to everyone.
I agree with Neil.
Thank you.
So well done, and thank you very much for the huge variety of cases that you've shown. Brilliant effort throughout the day. To all your team, congratulations. Thank you very much.
Yeah, see you all in yet another CSI, another place. Thank you.
Take care, Shiva.
Thank you.
That wasn't a recorded applause. So